Good morning. My name is Candy. I'm the house manager at Grace House in Akron. We are here today to start and go over our fourth module for the caregiver training that we've established here. So today's topic is management of symptoms at the end of life. So some of the symptoms that we sometimes see that can be features of illness defined by the person that may be experiencing them would be pain and nausea. We would look to see how often that person is having that, how long it lasts, and amount of distress that they may experience as a result of having any pain and or nausea. So signs and symptoms, to start off, we're going to just explore what are signs. These are things that can be seen by the observer, such as a fever may be a sign of infection, or lack of urine may be a sign of kidney failure. Increased respiratory rate might be a sign of shortness of breath. Symptoms, on the other hand, would be more subjective features of an illness that may be defined by the person who's experiencing them. So, for example, pain and nausea. That would be described by that person. How often would be the frequency, how long, that would be how long it lasts, the duration, and how much distress or discomfort it's causing the person. So with that said, why is symptom management important? Unrelieved symptoms can interfere with a person's everyday life. Things that they do on a day-to-day basis. It may cause them distress and suffering that really we don't want anyone to have to deal with, especially at the end of life. And it can decrease their quality of life. So not having as many good days and having more bad days, and that's what we want to alleviate. So looking at their whole picture, what all they're experiencing is really important. Managing symptoms quickly can prevent a negative cycle, and that would increase discomfort, cause distress and anxiety, causing more discomfort and leading to suffering, which is really not the ideal goal for someone at the end of life. As a caregiver, your role in symptom management is really important, because you spend more time with the resident and or family than any of the other disciplines that are involved in that person's care. You observe things such as signs and symptoms that others may not pick up on. So it's really important to report those things. So this can be observed just by listening and monitoring. When you are with the resident, you may notice their respiratory rate change, or their urine output is different, or if they're feeling really warm and you think they may be running a fever. These are things that you would want to report to me as the house manager or the hospice that the resident is affiliated with. You are talking with the resident and family a whole lot more because you are with them more. We want to make sure that, along with not just notifying our staff, but also with the hospice team that the agency that they're affiliated with, and providing that emotional support to the patient and or family. Those are things that you as a caregiver, it would be really important for you to do. Symptoms in hospice residents, they can have symptoms that are related and unrelated to their hospice diagnosis. So a lot of our hospice residents, they have diagnosis of cancer. So if it's something directly related to that cancer, as far as symptoms, you may see that, but there may be other things that may not be really related to the cancer that they may still experience. So whatever the resident may verbalize to you or kind of let you know about as far as symptoms, take heed to that, because whether it's something that's related or unrelated, it still is a symptom that they're having. Residents that are nonverbal or may not be able to communicate verbally to you, you may find that those symptoms are presenting themselves even with them not being able to communicate that to you. it may need to be addressed, but the lack of the ability to communicate that with the caregiver may be present because they are nonverbal. These nonverbal symptoms need to be explored as well. So it's still important whether they can verbalize it or not to notify someone of symptoms. So what are the most common symptoms that we could see in a end-of-life resident? Pain, of course, anxiety, depression. You may see some confusion or delirium, which is mostly like the restlessness, the terminal agitation, shortness of breath, fatigue, insomnia, nausea, constipation or diarrhea, loss of appetite, a dry mouth, an inability to regulate their body temperature, or incontinence of bowel and or bladder. These symptoms you may see in the hospice resident. It's important to recognize what the symptom the resident is experiencing so that you can properly address it with any necessary interventions. And that a lot of times may start out as you just notifying the nurse about those symptoms. That may be your intervention as a caregiver. Intervention, what do I mean by that? This is an action that can be taken to improve the situation the resident is having. So let's start out with pain and just talk about that a little bit. So residents that can verbally rate their pain, it's always good to ask them, what is your pain level from 0 to 10? 0 is no pain, 10 is the worst possible pain that you could have. This can, you can also use, and there's examples here in the slides to show you the Wong-Baker Faces scale, so that if they can't give you a number and verbalize that, they can point to the picture of the face that is more descriptive of their pain at that time. There's also the FLAC scale, it's FLACC, for assessing pain in a resident, and this is used for nonverbal residents or those who may be unable to use the other two scales, the number scale or the Wong-Baker Faces scale. Residents may be moaning, groaning, yelling, and or calling out, and that may be their representation of pain, especially if they're not able to verbally say, I'm in pain. Residents may have a furrowed eyebrow, like a grimace on their face, when you move them or just providing general care. That could be a sign that they're in pain. And if they're restless or agitated, that could also be a sign. So this is the Wong-Baker Faces pain scale as well as the numeric rating scale for you to kind of see what could be used. And I think we have copies of those that you would be able to access and use with the resident if you needed to. The FLAC score is the face, legs, activity, cry, and consolability. And each one is descriptive as to how many points based on what that person may be having, so that you can see if it was 0 points, they would have no, there would be disinterest in their face. Legs would be no position or relax, activity, normal position, crying, no crying, and consolability, content, and relaxed. And then thereafter you will see 1 point and 2 points what you would rate them on if they were showing any of those symptoms. Anorexia is the next symptom. That's lack of appetite and loss of desire to eat. Cachexia is wasting away or weight loss, which is a loss of muscle mass, and that occurs with weakness. So a lot of times with our end-of-life residents, they may not have an appetite, and this would kind of fall into that category. The lack of appetite occurs throughout the illness. Anorexia present in advanced disease stage and end of life. So a lot of times they may eat smaller portions of food, or they just may not eat all the meals that we're used to, like breakfast, lunch, dinner. They may only eat one meal a day. That's okay. Sometimes setting a full course meal in front of a resident like that may be too overwhelming, and it actually might cause them to feel nauseous and not feel good at all. So kind of take cues from the resident and know what might, where they're at in that point, where they may just want just a small amount or nothing at all, not to force them. Anorexia causes, it could be due to tumors of the stomach or esophagus, depression and or anxiety, increased pressure in the brain, mouth or stomach infections. Treatment related could be due to side effects of medications, mouth ulcers, or taste changes. So, and then some people just may not have the dentation, like they have poorly fitting dentures, or they may not have teeth at all, so it may just make it more difficult for them to eat. Things that you would see and you would want to report if you notice increased weakness, or the resident can't do their day-to-day activities, their activities of daily living, if they have a sore mouth or throat, if they have unrelieved heartburn or feel full after they eat very small amounts, no bowel movement in 3 days or more, history of difficulty with bowel movements, if they're sad or depressed or have like a dry mouth and chapped or cracked lips. Those are things that you would want to observe and kind of take note of. As a caregiver, you can identify some of their favorite foods, and again, offering those favorite foods and maybe smaller portions if that's what they need. High calorie, nutritious snacks, that's a great thing. Sometimes just kind of going along with what the resident may want, like if they want a bowl of ice cream, yeah, that might not be the most ideal thing in our world, because we're used to having, you have to have protein and vegetables, but in that moment, if that's all they can sustain, then that's okay. Providing good mouth care, supporting family and assuring them that the lack of appetite is common, that that's not something unusual or unique to just their loved one. This is a part of the end of life that the body just starts to see that it doesn't need as many calories or food like it did at one time. Avoid strong or unpleasant odors. Report any concerns that the resident and or family may have about artificial feeding or hydration. So that would be like the tube feedings or IV fluid. There may be concerns and desires that they may want that. So that at that time, you would definitely want to let the hospice providers know. Offer sips of favorite liquids. That could be ice chips, or just their favorite thing, like any juice or pop. Keep their mouth clean. We have a lot of the mouth swabs here that we can use, as well as the lip moisteners. If they're using oxygen, just take heed that we don't want to use any petroleum-based lip balms or anything like that. That doesn't mix well with the oxygen. Early disease with anorexia may include dietary consult, or it may just mean that the hospice providers order something to help their appetite, such as Decadron, Megace. For hospice patients, intense dietary and weight management rarely necessary. So seeing a dietitian and seeing if they need any type of dietary supplements or things like that aren't really needed at this point. And artificial nutrition and hydration is really not appropriate at the end of life. It can cause more harm than good. So that's why if the family or resident starts to question that, it would be good for you to let us know or let the hospice providers know. Bowel movements, we're going to get into constipation. So that would be defined as bowel movements that are infrequent for the resident. So this would be if they're going 3 days or more without having a bowel movement, and this can be caused to colon cancer, neuromuscular diseases, diabetes, or hemorrhoids. Usually medications such as opioids, which is a lot of what our residents are on for their pain and or shortness of breath, that will cause constipation. Decreased intake of food can cause constipation, inability to take in fluids or lack of mobility, generalized pain or weakness, all can lead to constipation because you're not able to move around like you did at one time. Things to keep in mind would be if there's a change in normal bowel pattern, if someone's reporting that they're having more straining when they're having a bowel movement, if the stool is harder, those are things you would want to report. If there's nausea and vomiting that goes along with that, any bloating or abdominal pain or just them feeling full, those are things you would definitely want to report. If they speak of any oozing of liquid stool, that would be something as well, or increase in gas, flatulence, pass without having a bowel movement. Those are things that if a resident mentions, you would definitely want to let the hospice providers know. Constipation, caregiver interventions, you can encourage fluids. That would be things, these are things that you can do as the caregiver. Suggest a warm drink like water, even coffee. Sometimes coffee can really get people's bowels to move. Provide privacy, encourage exercise if they're able to. Most of our residents at the end of life, they're not really strong enough to do a lot, but just maybe repositioning them or helping them up if they're still able to get up may be enough mobility to kind of help things, move things along. This slide is suggesting a warm washcloth to the rectum if there's rectal soreness present. But I would just say with that, definitely just see if that's an appropriate intervention at that time. Medications that are a lot of times ordered would be Colace, which is a stool softener, or Dulcolax, that's a laxative. Senecot, a lot of our residents are on Sena S. Sometimes they'll use suppositories such as Dulcolax. Haven't really seen too many enemas used, at least not here at Grace House, but they can use Fleet's enema. Psyllium seed or flax seeds are also herbal type preparations that can be used for constipation. Relistor may be used for opioid-induced constipation, which is a medication. The next symptom that we can see a lot at the end of life is dyspnea, which is shortness of breath. And you'll see that with the lung cancer, congestive heart failure, pneumonia, COPD, ascites, emphysema. So residents that have those types of conditions, you'll see the shortness of breath a lot more. Anxiety, if there's increased anxiety, that can also lead to shortness of breath. So what you would want to look for would be the resident reporting shortness of breath. If you notice or hear that they're having a lot of noisy breathing or gasping, if they seem anxious, if their nostrils are flaring like they're trying to catch their breath, any exaggerated movements of the chest and abdomen where they're really labored and working really hard to take a breath. Cyanosis, if it looks like they're blue, like have bluish tints around their mouth or even their fingertips. Restlessness, those are things that could lead you to notice more of the dyspnea. Intervention for that would be open a window or use a fan. Aim the fan directly at the person so that they're feeling that air, as long as that's tolerated by the resident. You can cool the room down. All of our rooms here at Grace House, we have air conditioned, so it should be cool, but all the rooms have a ceiling fan, so that can be turned on. If they need a fan that's directly on them, we also have those. You can help the residents sit up as upright as possible by putting the head of the bed up or just helping them to sit more upright. Important items, keeping those things that they need in that they would need to utilize in close reach, like their call button, or if they need Kleenex, or the remote to the TV, keeping those things so that they're not exerting too much energy to try to get them. Creating a calming atmosphere for some residents, that may be turning on music or turning the TV on to something that's very calming to them, or just looking out the window to see the beautiful patio. That may be something very calming, and providing emotional support at that time. Medications that you'll see utilized for shortness of breath or dyspnea would be the liquid morphine, which is the Roxanol, anti-anxiety medications like Ativan or Xanax, bronchodilators, the Atrovent or albuterol. We have a lot of our residents on albuterol, whether it's the inhaler or the aerosol that we use the nebulizer machine for. Sometimes they'll order cough suppressants. Very rare instances, if they need to, they'll order antibiotics or diuretics, which is like a Lasix that helps to eliminate the extra fluid that may be hanging out in their lungs. And then oxygen. Fatigue is the next one. This is something that most of our residents, by the end of life, or even leading up to that stage where they're actively dying, you'll see profound tiredness is what fatigue is, and it's usually unrelieved by rest. And this is with lack of physical and mental energy and weakness that interferes with all of their day-to-day activities. So they just are tired. The most common symptom that you'll see at the end of life is fatigue. And that could be caused due to anemia, infection, malnutrition. It could be a medication side effect. If someone's been recently through radiation and or chemo, that could be a side effect. Insomnia is a big reason for that. Some of the emotional factors with fatigue would be anxiety and stress, depression, family contact, or just spiritual distress. We see that in a lot of our residents. You want to then encourage, as a caregiver, interventions would be encouraging energy-saving techniques when you're assisting them with their activities of daily living. So, for example, having a bedside commode, instead of them exerting all that energy to try to get out of bed and walk to the restroom, having a commode there at the bedside. Even once they get to a point where they're not able to get up to the bedside commode, it may be a consideration at that point to try to ask the hospice providers to see if a Foley catheter would be appropriate at that point. Help the resident focus on activities that he or she would like to do. Promote as much independence as possible. Ensuring chairs or stools for sitting in long halls. Use grab bars or rails. So we have, like if they're able to get up to the shower room, we have shower chairs or a bench, because that would allow them the independence of being able to still get a shower, but still not exert so much energy where they have to stand there and stand up the whole entire shower. Other interventions would be encouraging frequent rest periods. So if you see that they just need a break, just allow them a few minutes to just rest and then go back to that activity that you're assisting them with, such as going to the restroom. Provide emotional support to the family. Encourage the resident to feel good about accomplishments and not be critical of himself or herself. Encourage pleasant activities that will help restore their energy, which would just be things that will help them to relax and calm down. And you want to make sure you decrease the risk of falls by making sure there's nothing that would be obstructing their walking or moving about in the room. Things that they can do for treatment for fatigue would be things such as medications like steroids or antidepressants, sometimes, not so much in hospice, but in other instances, there could be discussion about blood transfusions if someone's anemic and their blood count is really low. Management of things such as nausea, pain, or depression could also help with the fatigue, because that sometimes plays into when they have those symptoms, can play into a person having more fatigue. Mild exercise, if they're able to do that, just more like moving their legs, like when they're in bed, almost like a therapist would do, just kind of moving their legs back and forth, or allowing them to move their arms. And it goes into physical and occupational therapy. We don't really see that as much being utilized with hospice residents, but that is something outside of hospice that could be considered. The next symptom you can see at the end of life would be nausea and vomiting. Nausea is like just this upset stomach that's accompanied by a feeling of or a need to vomit. And vomiting is forceful expelling of stomach contents through the mouth or nose. This can be caused due to a variety of things that are listed here. I'll just point out a few of the most common ones that we usually will see. Again, if it's a cancer patient that maybe just completed chemo, that could be a side effect of the chemo, side effects of medications. Big one would be constipation. If they've really been constipated for a while, you may see the nausea and vomiting. You want to observe and report any upset stomach or them complaining of any queasiness or just that feeling that their stomach is unsettled. If they can't keep anything down like fluids and or food, that would be another thing to observe and report. If they have lack of appetite and they complain of having constipation where they have gone 3 or more days without having a bowel movement, those are things that you would definitely want to let someone know about. Report specific triggers such as strong odors, food, or anything like that that could cause them to feel more nauseous. Those would be important things to observe and report. Things as a caregiver that you could do if someone reports nausea and or vomiting. The list is here on the slide, and I'll let you review that. But I would say, as the caregiver here, doing frequent mouth care, because that's something that, especially when a resident gets to a point where they can't do their own mouth care, you would really want to be cognizant to do. Encourage the resident, if they're still eating, to kind of eat more slowly. You want to avoid strong odors of food or just any odors whatsoever. So just being mindful of that. Offer frequent small meals. Don't feel the need to fill their plate with food. That, like I said earlier, can cause a person to want to just feel nauseous, and it could lead to vomiting. So just be mindful of that. You could also offer a cool, damp cloth to their forehead or neck if they do complain of nausea. That may help. Things that we can do for nausea and vomiting, Haldol, Compazine, Phenergan, and Reglan are all medications that can be used and ordered for the treatment of nausea, and I'm sure we've all seen those medications ordered as needed. Hypnosis or acupuncture, we don't really get into too much of that with hospice residents, but that's just good information to know. The next symptom would be noisy respirations. It's called death rattle, and we usually don't say that around patients and or families, but most times the families will say that to you because most people have heard that and they know that's what they call it. So just be mindful that that's the same thing, but we as caregivers don't have to use that terminology. This occurs, it says, in comatose patients or when the death is near. So most of our patients, you will hear that excess gurgling or moist respirations. And that can be really distressing for the family. They start to think that the resident needs to be suctioned, and a lot of times it's not anything that you can suction, it's too far down. So just observe and report any noisy rattling that could happen in the upper airway or chest. If there's a lot of secretions in the mouth, since we don't do any suctioning here, even mouth suctioning, just using some of the mouth swabs to try to swab out as much of those secretions that you can. There may be drooling of secretions, and just kind of wipe their mouth and provide that mouth care. Family, caregiver report of any other symptoms, observe and report those things. So as a caregiver, you want to support the family and reassure them that the patient is not drowning and not experiencing distress. This is just a natural part of the dying process. Avoid the term death rattle, like we said earlier. Use words like congestion or noisy breathing when you're referring to this symptom instead of death rattle. And you can prepare the family that this is part of the final stages of dying. This is a normal process. You can reposition the resident. Positioning on the left side promotes drainage. Use pillows to support the resident and keep the bed with the head of the bed raised, and that'll help. Provide and suggest that you perform frequent oral care, which is what I said, just using mouth swabs to kind of clean their mouth out and make sure we can get as many of those secretions cleaned out as possible. And as I said, we don't do any mouth suctioning here, but if it were a situation where we did that, it could be, suctioning could be appropriate for the mouth, not to really try to get down deep. There's medications that can be ordered by the hospice provider to help dry up some of those secretions: scopolamine, atropine, Levsin, and Robenal. Those are really common ones. As I said, this is just general information. So on the slide, you'll see it say gentle suctioning of the mouth, but just know here at Grace House, we do not do any suctioning. So the next symptom, which many of you have experienced with a lot of our residents, is terminal restlessness or delirium. This is excessive restlessness with increased mental and physical activity. So when they're just constantly in and out of the bed, trying to climb out of the bed, sometimes it can be falls involved in it because they're not really knowing that they're weak and too weak to get out of bed. Some of the causes for this would be organ failure caused by chemical imbalances, and this can be worsened by medication side effects or dehydration, brain metastasis, which is cancer that has spread to the brain. Maybe if they're have insomnia, they're not getting enough sleep, that could lead to the terminal restlessness or delirium. Any unresolved fears or issues that the person may have related to dying. Things that you would observe and report: their inability to lay still, repeated attempts to get out of bed. They're picking at things, like reaching for things in the air or pulling at their clothes or bedding. They're undressing. If there's altered sleep patterns, like they may sleep during the day but awake at night. They're having hallucinations, thinking that they're seeing things that aren't really there. Sometimes residents will also, as they get closer to death, start to experience seeing people that have passed away before them. If their speech is garbled or confused, inability to communicate with others, their level of consciousness is changing. If there's family stress or exhaustion, you could see these symptoms. Provide emotional support as a caregiver. Make sure that you let the resident know who you are before you provide that care. Make sure the resident is safe. If you know they're getting out of bed, it may mean that we have to put a bed alarm on, or sometimes it may mean we have to push the bed up against one side of the wall so they can't get out both sides. Recently, we've had to have the hospice providers order a perimeter mattress to kind of help give some wedges on the side of the bed so that it's more difficult for the resident to try to get out of the bed. Avoid correcting the resident, don't argue. Avoid reorienting the resident, because at this point that may cause more agitation because they are so restless and having delirium. And you want to just make sure that you're supporting and encouraging and teaching the family, like educating the family about what's happening, and that this is a sign of a progression of this person's condition, and that they're getting to that stage where they're actively dying. Sometimes a gentle touch or massage, if the patient or resident can tolerate it, is helpful. Remove unnecessary items that could be thrown or broken that may be within the reach of the resident. As I said just now, attempt gentle hand or foot massage may be helpful. Decreasing the stimuli, like things in the room that could cause the resident to feel more anxious or restless. Turning down or turning the lights off, turning the TV off. Those are things that are increased stimuli that could really get them more energetic and restless. Maybe playing some calming music, and trying not to have a lot of loud things around, like even people talking outside the room or inside the room at that time. Medications that can be used for this would be Haldol, Zyprexa, lorazepam, Valium. We usually will see the Haldol and lorazepam a lot. Identify and treat causes of delirium, such as severe pain. We have not yet instituted this, but it's on the way. This next slide says, please review the predisposing checklist for delirium. This is something that has been developed by a medical student along with Dr. Ritwani. And I'll be doing this checklist, I believe, on the second day of admission when a resident is admitted to Grace House. And it gives us an idea of the likelihood of them developing delirium as they go through this end-of-life process. So I've included the link so that you can familiarize yourself with it, just so you know what's being rated and how we're rating it and what that means. So just take a look at that. The next symptom would be a feeling of anxiety. And this is apprehension, or just feeling worried or uneasy, or this feeling of dread. Sometimes people will have this if they're thinking about their future, or even the resident thinking about death and what that means and how that's going to impact the people that they leave behind. Like, all of that could lead to more anxious thoughts or feelings. Causes of anxiety could be uncontrolled symptoms, medication side effects, fear of the unknown, financial concerns or family conflicts, or spiritual distress. For you, you would want to observe and report if the resident is feeling anxious, worried, or they just feel like they're going crazy. That may be a description that they use. Increased restlessness or inability to find a comfortable position. Their respiratory rate is increased. They feel short of breath. Resident may report feeling their heart is pounding. They may be shaky and sweaty. You can physically see and observe that. And you might want to ask whether there are family or spiritual concerns at that point that may be causing them to feel anxious, or if they would like to speak with a social worker or chaplain, because they may have some unresolved issues that they want to talk through or talk out. So as a caregiver, you may not be able to address those issues, but listening to them and their concerns with empathy, putting yourself in that person's shoes and what they may actually be dealing with and why they may be feeling what they're feeling, would be like the best thing you could do. Provide reassurance, and not reassurance in the sense that you're giving them false hope, but just letting them know that you hear what they're saying, and you understand what they're saying, and you want to help, and see how that, what you could do to help. And maybe that help is just saying, I think maybe since you're feeling this way, we'll see if we can get a chaplain to come out to meet with you or visit with you. You might want to turn lights down or the TV off, again, decreasing that stimuli, anything that could cause them increased anxiety. So maybe not having them in a large area where there's a lot of people. Sometimes at Grace House, there's a lot of visitors that come in, so maybe not having them out in the open common area at that time might be the best thing. Medical treatment, again, some of these medications you may be familiar with. Xanax or Ativan are used for anxiety. Sometimes Paxil and Effexor, you may see those. Those are usually scheduled medications. The Xanax and Ativan can be given as needed if that's how it's ordered. Management of other symptoms, things that we've already discussed, may also help keep the anxiety down, such as managing their shortness of breath or their pain. Multidisciplinary approaches would be counseling, like I said, having the chaplain or social worker meet with the resident by him or herself or with family members. Social worker may be assisting to help the resident put his or her affairs in order. Guided imagery, helping them to see and get a picture in their mind to help them relax. Massage, that's not on here, but even a massage may help with anxiety. Progressive relaxation techniques or spiritual care. Depression kind of goes along with anxiety sometimes with some residents. That would be extreme and ongoing feelings that may include sadness, hopelessness, helplessness, or lack of self-worth, or anger. These feelings may occur just typically in a normal situation due to the dying process. If you know that you're dying, you may feel sad, you may feel hopeless and helpless. But if they're severe, this may indicate need for treatment. Some of the causes for depression would include diseases such as diabetes, dementia, thyroid disease, alcoholism, or brain metastasis. Medication side effects or withdrawal can also cause depression. Pain and or nausea, if it's uncontrolled, can cause depression. Just feeling emotionally like you don't have control over your life or what's going on in your life. If you feel like you're losing your independence, or there's some fear or spiritual distress, these are things that can cause or lead to someone maybe having some depressed feelings. If a resident reports feeling worthless or hopeless, or just feels like there's no reason for he or she to continue to live, those are things you want to take note of and report. Thoughts of wanting to hurt or harm himself or herself or kill others are definitely red flags that you should report. If there's increased crying episodes, interactions are very minimal to no interaction with other people, especially family, you want to report that. If you notice changes in appetite, yes, that could be due to fatigue or anorexia, but if you notice that along with these other reportable things, then you want to make sure you report it. It could be depression. Use active listening as a caregiver. You don't have to try to cheer the resident up. Allow that person to feel what they're feeling in the moment. It's okay. But we do want to make sure that the person is safe, the resident is safe, not wanting to hurt or harm him or herself. Try to encourage independence as much as possible, because that gives them that feeling of a little control, that they have a little bit of control over something in their life. Provide an opportunity for them to talk and remember significant events from the past that may be pleasant memories. Use coping mechanisms such as prayer or visits from key family members that may help them not to feel so down in that moment. Provide support to family. You can listen to their concerns. Encourage participation in providing care to decrease their feelings of helplessness. Encourage breaks from caregiving if they're, really tired out with certain things. And a lot of times that's what happens with our residents that may have caregivers at home. They sometimes get to a point where they are not able to physically and or mentally provide that care, and then they're seeking somewhere like Grace House to have their loved one come. So medications that can be used to help with depression: Elavil, Zoloft, Paxil. These are things that most times would be scheduled medications, so they will automatically be in the pill box, and you would just give according to when they're scheduled to give. Controlling other symptoms. Other things would be counseling or spiritual care involvement, guided imagery, massage. These are also things that could help with that depression. A summary of depression. This is an end-of-life symptom management is a challenge that requires the commitment of all care providers. So that would be hospice, that would be us. So all of us working together. There should be caregivers have an important role in observing, reporting, and intervening on behalf of the patient, because again, like we mentioned earlier, you're basically the ears and eyes. You're around the resident more times than any other discipline. So it's really key for you to be in tune with some of these symptoms, and just knowing when you observe different things, what you would need to report. Effective prevention and treatment of symptoms enhances the quality of life, easing the dying process for the resident and their families. So it's very helpful in making sure that we can address those symptoms when they come up, so that we give our residents more good days than bad days as they go through the dying process. So there will be a quiz that will be emailed out to each of you along with the recording of this slideshow. If you have questions or concerns, you can always reach out to me. You can reach me via my email, which is candice.hilton@gracehouseakron.org, or by calling me here at the house, but you can reach out to me. Also, the quiz will be emailed out so that you can go through it. Your answers will come directly to me. And then, like I said, if you have any questions about any of the content, please feel free to reach out. So thank you for your time. Hopefully it wasn't too long. This was a lengthier session, but we got through it. So have a great day. Thank you.